agonist forming. So you have to make your eyes go quickly one direction, slowly the other direction, and then also rotate.
What?
Yeah, it goes like this.
That sounds hard to demonstrate. Maybe I'll go give it to myself right now. I'll bang my head somewhere.
People under like 40, usually it's an impact to the head. Yeah, so I'm just planning to do like really quick anatomy and then one will be okay. And then will be it's all like yeah.
That sounds good. You can use me in any way you see fit. Hopefully we get some peeps here. Time to go live. Hey guys, thanks for tuning in so far. Another live day. What's up? What's up? Hopefully everyone's doing pretty good. Sorry for the audio. We have the heating unit on, so it will quiet down in a second. Maybe let Rob have like the. There we go. It's on.
Nice.
We'll give it a few more minutes, guys, and see how many people end up logging in. Maybe I'll turn the music down. There we go. All right. We'll give it a few more minutes. All right, Rob. How's your day been so far?
Today's been good.
Yeah?
Yeah.
That's good.
Yes.
I was expecting a longer answer.
It's been good, yes.
Good. Very good.
Yeah.
It's a big question.
Cleaning at the house this morning.
Nice. What kind of cleaning?
What
did you clean?
Bathrooms and floors.
Bathrooms and floors. Rob cleaned bathrooms and floors for everyone.
It was a team effort.
Yeah, did Naya help?
Wow. No.
No, okay.
She's not, yeah.
Probably made things maybe a little bit more difficult.
A little bit.
In a fun way.
In a fun way, yeah.
Thanks, guys, for tuning in. We'll give it a few more minutes. See who else will join us on this talk for vestibular rehabilitation. A very interesting topic.
It'll make your head spin.
Oh, you were waiting to use that one, weren't you? Rob was very excited about using that one.
Had that one loaded up since this morning. More to come.
More to come. All right. I think maybe this Instagram thing is lagging a bit. Brooke is here. How are you, Brooke? How is isolation? Silence. I think she's good. Oh, Zoom. We got to get more people, Zoom. Got to get more people logged in. 4 days left, but who's counting? So Brooke's in isolation. And that's it. I don't know what else to say about that. Everyone is in isolation, I guess, in some context. So I wish I could give you like lots of stuff to do, but I can't.
Just this.
Just this. I'll think of more ideas. Blogs. Mm-hmm. Lots of blogs. I need to write some blogs. Each day has been interesting. working on different, not even getting the projects I want done. All right. Okay, so, oh, there's not too many. I think it's lagging again. Andrew, you got to get some more of the physio peeps to attend. I'm going to put you on the spot. All right, we got some people joining. It's interesting to see the attendance every day.
Is it pretty like variable? What have you found?
I think it's leveled off. First day was quite good.
Mm-hmm.
Or it's all good. Every day's good, but it was pretty busy. But I don't know. Hopefully people don't find us boring.
I hope not.
I don't find myself boring at all. All right, so I guess we could get started, and then whoever comes in can catch up, I guess.
Yeah.
And it's recorded anyway, so there's be a link to this as well. You can always direct message and email us. So this is a good topic because I don't have any special training in this field. I have the basic training, and Rob can talk about some of the basic training physios get in school. And I guess obviously his higher level of education on the topic. So a lot of people have this. I've dealt with it in a lot of motor vehicle accidents, even some WCB claims and things like that.
Yeah, it's more common than you think. And we're talking about like vertigo and vestibular issues. But yeah, you don't hear about them all the time. But when you mention them, like almost everyone knows someone who's had this kind of problem before. And they are really common, like especially like you said, people with like whiplash after motor vehicle accidents. Like a lot of conditions, they're more common too in older people. So they account for like a large percentage of dizziness in people who are over like 60, 65 years old. So lots of different populations that can kind of maybe benefit from a bit of knowledge in this area. And it's also like kind of like a system and an area that people don't often like know much about until they have issues there, right? Like a lot of people kind of know some basics about like musculoskeletal anatomy, but when it comes to the vestibular system, people are a little bit more in the dark sometimes about it. So yeah, so like physiotherapy wise, there are like a number of physios, of course, who treat vestibular issues. At the University of Alberta, we got like a kind of a quick course going through it. And a lot of physios choose to do like further education in vestibular rehab if it's an area that they want to treat and work in. So I did my courses through the like dizziness rehab clinic, which is Bernard Tonks. He's an educator. I think he's out of Victoria now. He was in Vancouver for a while, but he does some great introductory and then more like advanced courses. He was in Edmonton just back in the fall.
Okay.
Yeah, I did my courses a few years ago though, and I've been treating like vertigo and vestibular patients ever since then. They probably make up maybe 10 or 20% of my caseload at a given time, depending. So yeah, so that's my background a little bit there. And like truly, it's one of my favorite groups to work with. I think that like the effectiveness of the interventions we can do for them are probably like tops when it comes to things we do as physiotherapists. So yeah, so it's really neat that way.
Makes you feel like a physio rock star.
It does, yeah. Well, especially with some conditions that we'll talk about.
Yeah.
You can get better pretty quickly.
Every day is a rock star moment for me, though.
But. Every single day, Monday to Friday. So yeah, so vertigo is a term that gets kind of thrown around loosely a little bit, but vertigo technically is the illusion of like movement in the room around you. So people will describe not moving, but feeling like the room is spinning around them, or feeling like they're kind of like spinning in the room. Most often it's kind of like a horizontal type of a spinning that we see, but it can be kind of a vertical, like kind of a head over heels type of a spinning as well. Yeah, so that's different from dizziness, like even severe dizziness, which is a more general term, or like unsteadiness, terms like that. And people will often describe severe dizziness and they'll say they have vertigo, which is fine, but as people treating it, it's important to kind of figure out is what they have true like vertigo, or is it like severe dizziness? Yeah, so again, that's kind of the technical differentiation between the two terms. And yeah, so we're going to talk about the anatomy a little bit of the vestibular system, which is the inner ear. So basically, it's a set of 5 organs that are in the inner ear, so close to your hearing organs. And you have 5 of these little organs on your left side and 5 on your right side. So let's see if we can get my illustration on the screen here. Let's see. You see that okay on both here? Try to get zoom, and then also the Instagram guys.
I can zoom it in, I think. There we go.
Try to keep the glare down a little bit here too. Anyways, yeah. So I just sketched this up this morning. So if anything's unclear here, as always, just post questions on the.
I'll do this better. Ooh.
Oh, sure, yeah.
There we go.
Have you got him there?
I got him there.
Okay, and hopefully the Zoom people here can see him okay too. I think the glare is a little bad, so I'm just going to pull the page protector off. See if that helps a little bit.
Oh yeah, perfect.
Is that okay there? So, so this is our guy right here, the smiley face. So he's looking at us. So this is going to be his right side and his left side. So the, mouth, nose, and eyes, and the inner ear, I just have marked off here with a little bit of an X. So it's a pretty small organ. And if you were to be able to see it from the front of the face, it would almost be kind of right behind the eyeballs. So deep in the ear canal like that. So if we take this gentleman and if we blow up his left inner ear, we can see the 5 different little organs that it's composed of. So the 2 that I have in green here are called the otolith organs. So their names are the saccule, which is more vertical, and the utricle, which is more horizontal. So if we take our utricle here and we blow it up even further, it's kind of like a kidney bean shaped organ, just like this. So not perfectly circular or oval, and it's full of kind of like a thick syrupy fluid called endolymph. So they say that it has the same kind of viscosity as maple syrup, maybe the same flavor. I have no idea. I don't know if anyone knows, but so kind of a thick syrupy fluid, and that same endolymph, that same thick fluid, is actually found in all 5 of these organs, and it actually flows from one to the other. So it flows from the otolith organs through the canals, and then it flows out of the inner ear through a duct called the endolymphatic duct. So you can kind of like imagine this whole system as being like a really slow, lazy river where you have this like syrupy fluid kind of making its way through. So each of these organs has its own distinct function. So if we're looking again at the otolith organs, so the saccule and utricle here, their role in the inner ear is going to be like a tilt detector. So on the bottom of the organ, we have these little hair cells, little cilia that I've drawn up as little vertical lines. And on top of the cilia, we have the little, we call them like otoconia or ear rocks or little calcium carbonate crystals. But basically they're little heavy crystals that sit on top of that layer of hair cells. So when the head tips to one side or to the other side, those heavy crystals are going to bend the hair cells. And it's that bending of the hair cells that kind of triggers the electrical signal to the brain, telling you that your head is tipped one way or the other, if that makes sense so far. And these organs, they're sensitive to within about 2.2 degrees or 2.5 degrees, somewhere in there. So they're a really sensitive system for letting us know whether we are kind of truly vertical or if we're off axis at all that way. So that's our otolith organs, the little green pods. If we take one of these blue guys here, so these are called the semicircular canals. So again, they're full of that same syrupy endolymphatic fluid kind of flowing through. And these ones are more of a kind of like a garden hose setup. So they have kind of a membrane around the outside and then a cavity on the inside with that fluid. So if we take they each have different names, of course, too. So we have the anterior canal, the posterior canal, and the horizontal canal. Since we have this same organ set up on either side of the body, one set in your left, one set in the right inner ear, each of these canals has kind of a paired canal on the opposite side that's going to be sensitive to the same movements. So if one of these canals were to be knocked out for some reason, theoretically its kind of sister canal on the opposite side
would be able to take over that role, and you'd still be able to function without any of these organs. So yeah, each one kind of has a redundant pair on the opposite side. If we take the posterior canal right here and we magnify it a whole bunch, yeah, basically it's going to look like this. It has a little kind of bulby area on one end, where again we find those little hair cells, those cilia. So the function of the canals is going to be, they're going to work as angular acceleration detectors. So if you kind of think of, if you have a glass of water and you turn the glass really quick, the water inside isn't going to start moving right away, right? It's going to stay still. So in the same way, when you turn your head in any given direction, you're going to be moving the canals because they're attached, but the fluid in the canals isn't going to start moving that same direction right away. It's going to take a little bit of time to get going. And it's that kind of relative counterflow of fluid, in this case, that's going to bend the hair cells in the bulbous portion here. That's going to let your brain know that you're kind of rotating or tipping your head one direction or the other, as well as kind of the direction and the speed of that movement. So we had, again, the otolith organs here. Those are kind of your tilt detectors. And then we have the semicircular canals, which are kind of your angular acceleration detectors. And this kind of like leads us into the first and the most common vestibular condition that we treat in physiotherapy. And this condition is called BPPV, or benign paroxysmal positional vertigo, which is, yeah, it's a pretty long name. So yeah, BPPV for short. It's a name worth shortening. The name basically, like, benign, so it's non-life threatening. It's positional, so it's going to give you vertigo when you're in a certain head position or with a certain movement, and then the V is vertigo, of course. So what happens with BPPV, and this is just illustrated down here in the corner, if you can make that out, is the little otoconia, or calcium carbonate crystals, they become kind of jarred loose from the hair cells they normally sit on. And this can happen for different reasons. People who are under maybe like 30, 40, mid 40s, usually there's going to be like kind of a trauma involved. So these are the ones you might see after like a car accident, or if someone gets, like, maybe they fall on the ice and hit their head, or like a hit in hockey or in sports, those kinds of things. In people who are like over, even like late 30s, or definitely like over kind of 40 years old, usually they're just going to become kind of loose spontaneously, and we're not sure why that happens. There's different theories about like maybe blood flow changes to the inner ear and those kinds of things. But yeah, for whatever reason, traumatic or non-traumatic, the little calcium carbonate crystals become loose. So when that happens, again, remembering that we have that kind of slow, continuous movement of fluid through the canals and the otoliths, the heavy crystals are going to find the lowest point in the system. So if we're kind of down here in the corner again, we can see those little crystals are going to find most often the lowest point of that posterior canal. You can also get BPPV of the horizontal canal, or potentially the anterior canal, but by far most commonly we're going to get it happening in that posterior canal. So once the crystals are in there, what you're going to get symptomatically is, like, let's say you go and lay on your side, so you're in this position. Those crystals again are going to move down to the lowest point of the canal based on gravity, and that movement of crystals within the canal is going to get the fluid moving. And when your brain knows there's fluid moving in the canal, it thinks that your head is turning. So what ends up happening is, even though you're stationary, you're kind of getting the impression that you're moving in the room, or the room is moving. So you're going to get that true vertigo or kind of room spinning sensation, even though it is in fact not spinning. So that's what you get with BPPV anyways. And yeah, like about half of the doctor's referrals that we get for vertigo end up being BPPV. It's the most fun to treat. Like, it kind of responds the quickest. It's entirely like a mechanical issue. Yeah, otoconia in the wrong place. When you move, they're going to become symptomatic, and the treatment is like relatively straightforward. So with kind of an understanding of the anatomy and how gravity works, basically you're going to move your patient, or be moved by your physiotherapist, through a series of head movements. The series is going to depend on which canal is affected, but basically we're just kind of moving the canals around until those ear rocks drop back into the utricle. So it's kind of like the little marble in the maze game, where you're kind of moving the maze around until the marble drops out.
I was never good at that game.
Yeah, so we'll kind of get moving around here a little bit. So I'm just going to demonstrate kind of the assessment technique that we use for BPPV, as well as the treatment technique that we use for it. And then after that, we'll talk about some other conditions. So yeah, we'll make our way over to the bed.
Yeah, let's go to the treatment bed. Clinic. That's a good view.
Yeah, that's good.
That's probably good.
I
Yeah.
think so, yeah. We're actually,
I can probably push it a little bit further.
yeah, even if we could get like a little bit wider.
Yeah.
Nice. Then can you tip it up a little bit? Like from,
Like up like this.
yeah, is that possible?
Yes,
It's okay if it's not.
Everything is possible. Impossible is nothing. I've heard that before. Okay, is that good, Rob?
Try to give people the best view. That's perfect, yeah.
Oh yeah, that's good, I think. Yeah,
Yeah, that's fantastic.
you can use a stool if you want.
And then, sure. And Sunny, if you don't mind sitting up on the bed with your feet facing the window.
Yes.
Just a long sit position this way. Perfect. So, yeah, here, I'll crouch down a bit to get in shot here too. So, this technique, it does involve some quick movements, some neck rotation and some neck extension. So before doing the assessment or the treatment technique for BPPV, we would always be checking Sunny's like range of movement and his positional tolerance for the positions that we're going to use. So we usually wouldn't kind of get straight into it this aggressively, but we know Sunny's in good shape. He's got a good functioning neck,
Yes.
and hopefully no vertigo, because we don't want this to get too real.
No. No.
So yeah, so basically for our assessment, we have, again, keeping in mind that there are 3 different canals on either side. So we're going to do an assessment technique for Sunny's, we'll do his left posterior canal. So basically with the first part of the movement is going to be dropping back onto the pillow right here. So before we do that, to get a bias of that left canal, I'm going to get Sunny to look over his left shoulder, just like that. And when we go back, his neck is going to go back into a little bit of extension. So it's nice with these beds with the headpiece that moves, because we can tip it down to allow that movement to happen. If we were on a flat bed, we could use pillows behind his upper back, or we could have him go off the edge of the bed to enable that bit of neck extension. But yeah, basically, I'm going to explain to Sunny that on my 3 counts, I'm going to say 1, 2, 3, drop. And on drop, we're going to go back, not on 3. The idea is you want to go as quickly as you can comfortably. So I'm going to be here to support you, but I'm not going to force you backwards. Yeah, there's different kind of like techniques, different ways people do this one, but I like to have some support back here and some support on the front. A lot of people who have vertigo will feel quite like apprehensive and quite unsteady with this. And also knowing that it's going to provoke their symptoms can make them feel uncomfortable sometimes. It's important to explain that as long as they stay relaxed, there's no way they will fall off the bed. The only way they'll fall off is if they physically kind of push themselves off. So they may feel like they're falling off the bed because of their vertigo symptoms, but it's important to kind of let them know that they need to stay as relaxed as possible. And I'll usually have an arm in front of them as well, and often they'll choose to kind of hang onto my elbow, so they kind of have that kind of tactile kind of stabilizer in front of them, just to kind of help against that sensation of rolling or fall. So it's going to look like this, and I'm kind of stabilizing from here. You can hold my elbow if you want to. And again, I'm going to say 1, 2, 3, drop, and on drop, we're going to go back. I'm going to keep your head supported, and Sunny, if you can keep your eyes open, that's bonus points. And let me know how you're doing.
Yes.
So we're going to go 1, 2, 3, and drop, just like that. So this is called the Dix-Hallpike test. So this one, in this position, is testing for both the left posterior canal and for the right anterior canal. So it's a 2-for-1. So if we got back in this position and we had a positive test, Sonny would let me know that he was feeling those vertigo symptoms, so the room spinning. And if I was looking at his eyes, I would also see what we call a torsional jerk nystagmus. So the eyeball basically is moving slowly in one direction and then quickly in the other direction. So it sort of looks like this. And with BPPV, it's also going to have kind of a rotational component too. So it's going to be moving quickly and rotating one direction and slow with the rotation in the opposite direction. If we can see the patient's eyes to know if the quick phase of the nystagmus is either going down or going up, that lets us know if it's Sonny's left posterior canal or if it's his right anterior canal, both of which are being stressed in this position. So if the person is very uncomfortable and has to close their eyes, that's okay. It doesn't necessarily change our treatment right away at the moment, but I always tell them that if they can keep their eyes open, that's bonus. So basically, we're kind of giving him time in this position for those crystals to move down to the lowest point in the canal, kind of based on gravity where his position is right now. So usually we'll kind of like wait for his symptoms to clear, which will happen in about 20 to 40 seconds, usually at the shorter end of that range. Then we're just going to wait for about 30 seconds longer. And you can go even a bit longer than that if you want to be extra safe. And then from there, the next movement is going to be a neck rotation from the left to the right. Hopefully I'm still in view here. So I'm going to tell Sonny just to relax, and we're going to go around to that right side, maintaining a bit of that neck extension as we go. Same thing here. You might get a kind of a fresh bout of symptoms. We'll likely see some of that torsional nystagmus again. And again, we're going to wait for that to subside, plus about 30 seconds more. Our next movement here is going to be getting Sonny to roll onto his right side. So yeah, bend that left knee up. I'm going to be in charge of your head, but we're going to keep that nice right rotation. Perfect. And same thing from here. We might get like a fresh round of symptoms.
Ooh,
and
everything's spinning.
Just like that, yeah. And same thing, we would kind of give him the time for that to subside, plus about 30 seconds more. And then our last position change will be getting Sonny to bring his feet forward over the edge of the bed, and then prop himself up into sitting, just like that. That's all there is to it. So the testing portion there is called the Dix-Hallpike test, and that maneuver is called the Epley maneuver. And again, that one's designed for clearing that left posterior canal, BPPV. We won't demo them all now, but there are different techniques, again, for those canals. If we're not successful with the Dix-Hallpike Epley combo, we can do a side-by test with a Gons maneuver, for example. And for that horizontal canal, which is the one that we can't get with this maneuver, we would do something called a head roll test to assess, and then something called a barbecue roll to treat it. So yeah, they all sound fun, right? Well, that's good. Let's head back over to the podium.
Oh, there's me. 1 second. 1 second. Just gotta level this thing off. There we go.
Well, maybe I'll get you to pull up the nystagmus video here.
Oh yeah, I can do that.
And I can. Maybe we're going to be used to people looking at the computer screen for the moment, eh?
Yeah. Where did it go? There we go. So, oh, share screen.
Okay, yeah, here it is.
Yeah.
So we talked about that torsional jerk nystagmus.
this message?
So this is just a quick little online video, just to show you what that looks like here.
Oh no.
Oh, that cut off a little bit.
Why doesn't it
It's kind of strange, eh?
show everything? Okay, well that was not.
Well, anyways, you can see the very edge of it right there.
Oh. I don't know why that's happening.
But you can see that the quick phase of the nystagmus is going towards my left-hand side from where I'm looking at it here. Away from the up next panel anyways. And then the slow phase is back towards the panel.
Well, sorry guys. That worked when I wasn't screen sharing it. I guess actually we can show it if I stop the screen share, and I can forward undo the full video. Actually, wait.
Yeah, there it is.
Where is the...
Yeah, that's it right there. So you can see that the nystagmus is kind of going in like more or less a horizontal versus a vertical direction. And depending on kind of the quality you can see there, you can even see from the iris that little bit of rotation, and then it stopped for him there. Yeah, beautiful example.
There we go. I can forward you the link for the video. Oh, let's There we go.
Yeah, so again, like with our Dix-Hallpike test that we just did there, we'd be getting the patient to keep their eyes open if they can. And if we can observe that torsional drift nystagmus, that's a really strong indicator that they do in fact have BPPV and not another type of vertigo. And it's like a very good test. So usually when we get them back in that position, if we do get that like strong vertigo response with that characteristic nystagmus, I'm always really excited, because the Epley maneuver that we did to correct it just there, it's extremely effective. So if they do in fact have BPPV, often it's a very quick correction. We might do the Epley maneuver, a retest. If they still have symptoms, maybe a second go through the Epley, and often they feel like close to 100% even walking out. So yeah, those are like the really fun ones to treat, are the BPPVs.
Yeah.
Yeah, in a second we'll get into a couple other causes of vertigo and vestibular dysfunction. But does anyone have any questions about that benign paroxysmal positional vertigo right at the moment?
I'm just looking back. So far, no questions. But...
Okay, nice. Well, yeah, if any pop up as we go, we'll just take them as they come.
Yeah.
But yeah, like as far as symptoms of an inner ear condition go, vertigo is kind of like the characteristic one, but there can be many others as well. So you can get just plain old dizziness from a vestibular issue. You can also get stuff like headaches. You can get like a drift when you walk. You might find that you kind of like tend towards one direction, anything like that. Some people will get like really severe sort of like motion sickness type symptoms, where they're getting like headache, nausea, and yeah, the vestibular system, it never works alone. It's kind of part of like a team with our balance systems, right?
Yeah.
So not only do we have one inner ear on either side, but we also have our other balance systems, which are like our visual system, for example, and our like our kind of proprioceptive system, which is the information that we get from our joints and muscles when we move. And the brain is always getting information from all of those systems and then kind of interpreting it smoothly. So like, for example, if I turn my head towards my right-hand side, my brain's going to get information from either inner ear, telling it that I'm making that right rotation at maybe 45 degrees per second. My neck muscles contracting and ligaments being stretched are going to give my brain that same information that I'm making that right-hand turn. And then my visual system, as my kind of visual field shifts towards like my left relatively, that information is all going to line up. And when it doesn't, you feel really lousy. So an example there is like is car sickness.
Oh,
So if you're driving, or say you're in the passenger seat and you're on your phone, in that case, your visual system is looking at like a non-moving environment, looking at your phone screen or your book or the inside of the car, but your body is kind of feeling that acceleration, deceleration of the vehicle. Your vestibular system might kick in a bit as your body goes, or as your car goes around turns, that kind of thing. So again, it's kind of a mismatch where like the visual isn't lining up with the vestibular and the proprioceptive necessarily, and it makes you feel nauseous because your brain doesn't like what's happening. So it's going to let you know, like, hey, I'm unhappy. So it's going to make you feel lousy because it wants you to do something about it. And you'll get the same kind of thing happening very often with vestibular issues, because again, you have that one dysfunctional like canal in the case of BPPV, and the information from the canal, it's not lining up well with other information the brain's getting. So again, it wants you to do something about it. So it's going to make you feel lousy, yeah, all that good stuff. So you see all kinds of symptoms anyways.
Yeah.
Anxiety
Lousy
as well is like a
symptoms.
big one. Yeah, lousy symptoms
Lousy
too. Yeah,
symptoms.
maybe worse than pain. I don't know. I guess it's all
could be.
relative.
I guess so.
Yeah, the worst symptom is the one you have, right?
Yes, correct.
Typically. So yeah, and again, if anyone has any BPPV questions, just fire away. But otherwise, we'll just talk really quickly about yeah. So as far as treatment goes, we kind of have BPPV, which is that mechanical issue with that mechanical assessment and treatment that we just did. And then we have kind of another group of vestibular issues. And sometimes we'll kind of call these UVLs, or unilateral vestibular lesions, or sometimes BVLs, which is a bilateral vestibular lesion. But basically it's any kind of condition that'll make one of your inner ears not work as well as a healthy one or as your good side. So it just causes like an imbalance. So one that we kind of use as an example of that is a vestibular neuritis, which is kind of a nerve inflammation that's going to affect the superior vestibular nerve, which is responsible for the utricle. From the other sheet there, utricle is one of our bean pods, and then the anterior and horizontal canals on the side the nerve is on. So whether it's your right or your left side. And what ends up happening there is basically it'll change the conducting velocity of that nerve. So if yeah, so we're back to our guy here with his right hand side, left hand side, and again our little X's here are going to be his right and left inner ears. So if we kind of just take the inner ear generally, if I'm sitting here at rest, both of my inner ears are going to be firing signals to the brain at kind of a consistent rate of about 100 hertz. So I'm not moving, so right and left side are both going boom, 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 100 hertz, sending the brain signals. When I move or tip towards one side, the side I'm moving towards is going to become more excited. It's going to start to fire a little bit faster. And the side I'm moving away from is going to become a little bit inhibited. It's going to start to fire a little bit slower. And again, that's going to depend on the direction and the speed of my movement. So for example, with this guy, so if he's at rest right here, he's got that nice even 100 hertz on either side. If he goes and makes kind of a right hand, maybe a shoulder check over his right hand side, his right inner ear is going to become more excited. It's going to increase to about 150 hertz in this example. The left inner ear is going to make the exact opposite move. So right goes up by 50 hertz, left goes down by 50 hertz. The brain likes this. It's used to getting that signal. 150 and 50, it's seen a million times before. It probably matches up with what his eyes are seeing and with what his like neck and muscles and ligaments and tendons are kind of experiencing at the same time. So all is well. If we take our happy guy here and we give him, let's say like a right-sided vestibular neuritis, yeah, usually with this condition, you're gonna kind of get like a cold or a flu at the same time, and then it's going to kind of like get into that nerve where it's going to affect the function of the nerve. So people will often say that they were like sick for a week or sick for a few days, and they woke up one day and the room was just like spinning like nuts, like just crazy vertigo. With BPPV, usually we kind of had that like 30 to 40 seconds experience of vertigo that would stop as long as we weren't moving. But with these ones, usually it'll be like longer lasting. Like you can have it for like up to 2 or 3 days, sort of off and on when you're in the really acute phase with something like a neuritis with a UVL in this example, because it isn't that mechanical stimulation of moving that's causing it. It's the actual dysfunction of the nerve. So regardless of your head position or whether your eyes are closed or open, that nerve's going to be dysfunctional, and it's going to give you that vertigo sensation for a longer period of time. So usually you'll get sick, you'll have kind of that bout of vertigo that can last a couple of days, and then people will find that like they kind of feel okay as long as they don't move in a certain way. But if they do, they feel miserable again. That's going to be like kind of our characteristic like history that we're going to get. That's going to point us towards something like a neuritis, like a UVL again, rather than like a BPPV cause of vertigo. So let's say we're seeing this guy like a week after his kind of big vertigo flare up. Now he's like pretty good as long as he doesn't make any funny movements. So what happens basically, so we gave him neuritis of the right superior vestibular nerve. So now his right side is just not firing as effectively as it was before. It's a little bit slower. So when he's not moving, he's sitting there in front of you. His left side, it doesn't know what's going on the right side. It's still happily firing away at 100 hertz. But his right side now is going to be just a little bit depressed. So now it's firing at about 80 hertz. And we just picked an arbitrary number, but it's going to be some value less than 100, kind of severity dependent. So now his right side is firing a little bit slower. But after a week or so, the brain has kind of gotten used to this pattern because it's been getting 100 hertz, 80 hertz all week. So after those 2 or 3 days, it kind of figures out, okay, 80 hertz, that's like the new 100 hertz. So I can kind of turn off the alarm signals now. Yeah, you can kind of use like the metaphor of like an airline pilot. So he has his gauges, he has what he can see out the window, and then he kind of knows what he's doing with the controls. So if one of his gauges starts to go funny, there might be a few minutes of panic where he thinks that maybe the plane's like, maybe it's nosediving, or maybe it's climbing too rapidly or tipping one direction. But after a few minutes, kind of knowing that he's not changing the controls and seeing what he can see kind of visually through the front window, he might decide, okay, everything's all right. Like we're not crashing. It's just my instrument that's dysfunctional, and he can kind of ignore that for the time being. And the brain will kind of do the same thing. So when it's getting, in this case, the one nerve, and the information it's getting from that nerve just is not making sense, after a few days, it'll start to just kind of tune that out a little bit and to kind of get used to that 80 hertz as the new normal. So seeing this person like a week post illness, they'll be okay sitting there at rest in that 80 hertz, 100 hertz condition. The brain's kind of adapted to it. But when they go and make, let's say, that same right hand shoulder check, again, left side is going to behave normally. It's going to come down to 50 hertz like it normally would. The right side might still go up by 30 hertz, or sorry, by 50 hertz. But now instead of hitting 150 hertz, it's only going to get to 130 hertz. So 80 hertz plus 50 hertz, 130 hertz. And again, this is a brand new combination for the brain. It's never seen 50 hertz and 130 hertz coming in at the same time. It might be used to like 130 hertz with 70 hertz, which would kind of correspond with a slower right head turn. And it's used to 50 hertz, 150 hertz, but it's never seen 130 hertz and 50 hertz. So again, this person might get like nausea, headache, any kind of symptoms like that, and dizziness and vertigo at the same time because they're getting that inner ear dysfunction. So yeah, so this is kind of like the rest of conditions that we treat, like more or less, the non-BPPV conditions. And these ones we manage differently. So again, it's not that mechanical cause of symptoms. So we can't treat them with the Epley maneuver or the barbecue roll or any of those kind of mechanically based treatments. So for these patients, we're going to treat them with an exercise program. So yeah, so basically the exercise program, rather than being diagnosis specific, is more so going to be symptom specific. So making a diagnosis can still be important because there are conditions with the inner ear that we can't effectively treat as physiotherapists. So something like a MAV, which is a migraine associated vertigo. So people with that condition, they'll have a migraine like people with migraines do, but one of their symptoms is going to be like a vertigo spell. So for those people, the best treatment is to try a migraine medication. And if that helps with their migraine, it should also help to relieve their vertigo symptoms. That can also be diagnostic. So if taking like their migraine medication gets rid of their vertigo, then it kind of confirms the diagnosis of a migraine associated vertigo, and that's going to be your treatment for that. Likewise, there's conditions like Meniere's disease, which kind of involves the endolymph again, that syrupy fluid. And I mentioned that it kind of flows out of the inner ear through a duct. So when there's a dysfunction in the duct, it basically becomes overfilled with fluid that causes inflammation of the whole system. That'll be a condition that kind of comes and goes. You'll have flare-ups. It might settle a bit in between, but you're basically going to have progressively decreased function of that inner ear until it's entirely dysfunctional. So the exercises that we would normally prescribe to kind of restore function, they're basically, we're kind of working with a moving target for those people because their condition is going to be changing all the time. So typically for them, they kind of have to, starting treatment early is not a bad idea anyways, but they kind of like will want to bottom out, and then treatment can be more effective from them from that point. So anyways, that was like a long aside, but yeah, diagnosis is still important. But basically, once we've kind of like ruled out more serious pathology like that, if we find that we're not dealing with BPPV, then our next step is going to be to try to find areas where the person's inner ear has weakness. So in this guy's example again, if it's only that right head turn that's causing his symptoms, treatment can be as simple as getting him to make those right head turns throughout the day with enough intensity and frequency to bring on his symptoms. So by doing that, we're forcing the brain to kind of integrate that new information and adapt. And over time, he should see less and less symptoms with that movement, in the same way that kind of a still head movement became less symptomatic after 2 or 3 days. So that's a kind of a really simple example, but people can have all kinds of deficits with a vestibular injury, and our treatment is going to basically be based on those areas of weakness. So yeah, that's basically it. So we're just kind of challenging the system in ways where it's weak, in the same way that we would kind of challenge the musculoskeletal system if someone had weakness in a muscle or a tendon issue. And a lot of the same principles can apply there too, where you're going to want to be like specific to the part of the organ that's dysfunctional. You're going to want to progressively load it. So starting with like easier tasks and progressing to ones that use maybe more of the system, and keeping the intensity high enough that it does provoke some symptoms, but allows them to settle within a reasonable amount of time. So again, those are all parallels with treatment we would do for musculoskeletal conditions. Yeah.
Let's go back. All right. So for you guys that just joined, sorry, you missed a bit of this. Any questions about anything that Rob went through? I want to say Rob and I, but I literally did nothing for I was the camera person, so if there's any
fantastic one.
well, thank you. Any questions at all about vertigo, anything like that? Now we wait. Oh, I know what we can do tomorrow. We can start with dad jokes. Hey, that'd be fun.
Dad jokes are my favorite jokes.
Okay, good. We're gonna do that tomorrow. That's gonna be the beginning banter. And if I'm alone, I'll do it. I'll just like it to the wall or something like that. No questions yet. Yeah, that was a good explanation of vertigo. Very good. I learned some new things there as well.
Oh, thank you. Do you have any questions at all?
No, I don't think so. I mean, being at this clinic is pretty good because if I have a case, and this has happened a number of times, a couple times, I think, and I can just refer to you. That's a good thing about being physios that have different skills. We all, kind of get the bread and butter in school, learn certain skills, and then kind of branch out and do whatever we like. So yeah, if I find a lot of TMD cases, so a lot of cases I treat for the jaw have these kind of issues as well. So we can co-treat and then come up with a great plan. So I don't have enough money to take the course right now, so I don't want to compete against anybody, especially at this clinic.
But yeah, it's a great course.
Yeah.
Bernard Tonks, great guy, humble, intelligent, funny, Yeah.
A gentleman.
Hopefully he's watching.
Oh. Oh, we got a question. We got a question. How long do you typically find someone with vertigo that isn't from BPPV take to recover with habitual exercises?
Mm-hmm.
That's a good one.
That's a really good one. Yeah.
That's a solid question.
And usually they should start to see improvement within a few weeks. They should be seeing improvement within like about 6 weeks.
Yeah.
Which I know is a long time frame, but some people have these conditions that go on for years and years. Yeah, like studies I've seen, 6 weeks is kind of a time point where you're going to reliably be seeing some measurable changes, and then things will continue to change over time from there too. So yeah, 6 weeks plus.
Yes.
But in the studies I've seen where people are not prescribed exercises, their symptoms stay consistent over time.
Okay.
So it's, if you're in the control group, you're probably not seeing any change at all. So, so some change at 6 weeks is pretty good.
That's pretty good.
And again, that's in like major contrast to the BPPV people, of which like 80 to 90, 94% will have their symptoms resolve within a treatment or two.
Right. That's good. I think that answers that one pretty good. Another question, could you discuss more the connection between TMJ and vertigo? So TMD and vertigo, I find the cases that I worked with that have had both issues was lots of motor vehicle accidents from what I found, or even people that have had dental work as well. So I think that, I know I have some assumptions of the causes, like of how it happens, but for the TMD, or the TMJ issues, I find a lot of the times it's because of impact, like especially with the motor vehicle accident, your whole body shooken up, so to speak, and then you have injuries in a number of areas that I assume can cause the vertigo as well, if the crystals are kind of like how the canals you explained are not in place.
For sure, especially the BPPV type again.
Yeah, and then I find with dental work as well, if your mouth's open for a prolonged period of time in a weird posture, which normally doesn't happen. Usually when you eat, your mouth might be wide, but you chomp down. You can develop a lot of TMJ issues through that, and they're not significant to treat. Like the treatment's pretty straightforward. And I find if you're in awkward positions, that could also probably cause some vertigo as well.
Mm-hmm. Dental work's a funny one. I treated a guy in Kelowna 3 years in a row, a couple treatments each year, and always the same week in April. Yeah, because he would have his routine dental cleaning on like the Monday, and after the first year, he would just book physio treatment for like Tuesday. Yeah, and like every single time, I think it was maybe the vibration from the tools plus the prolonged head position. Yeah, it would give him BPPV. So 3 years in a row.
Oh my gosh,
so that was like a funny
It's interesting. One. Those kind of cases are interesting. I've always have like a few people in the past that always came during exam time. So students, a lot of stress, a lot of like biting down and things like that. So they'd always come in for like 2 treatments and that's it. And then the next exam period. So
an annual thing.
Yeah, that was very straightforward to treat, but it was pretty fun. Another question, if someone is in that 6-week time frame, how often do you tend to see them in the clinic? So I guess treatment frequency.
Yeah, usually for the non-BPPV cases, it's fairly like infrequent treatment. Like the benefit they're going to get is going to be gradual and from the home exercises. So I might see them like once a week for the first couple of weeks, just to check in after a week of exercise to make sure that things are going smoothly, that the intensity is manageable for them. And then after that, it can be a couple of weeks between treatments. And sometimes it can depend on how they're doing as well. Yeah. After I've seen them a number of times and their home program is going well for them, they're doing exercises like consistently and properly, it might just be a case of like, send me an email in a few weeks. Let me know how you're doing. If you need a top up or a progression, then stop by. But people who are going to take like months and months to get to 100%, they're typically going to be like gradually more spaced out as time goes along.
That's a good question. I agree with all of that. And we'll give it a couple more minutes. I think we only have like 5 minutes left, but as I found out last week, Instagram kicks you out after an hour, and then I had to restart.
I thought I was going to be so fast today.
That's what we discussed. We're like, oh,
Yeah.
we're just gonna do this in 10 minutes.
Yeah.
No, not 10 minutes, but yeah, we'll wait a couple more minutes. I think that addresses all those questions. Yeah, it's interesting to see the links of different conditions together in the body. So there's a good question about TMD and vestibular rehab
Mhm.
and vertigo. So it's nice to be able to treat all those things.
Yeah. I think like the neck too can also be,
Yeah.
is I think a big thing with TMD as well.
Yeah, exactly.
And,
Yeah.
and with vertigo.
Yeah.
Some people will get dizziness as a result of an injury to the neck. So we'll call that like cervicogenic dizziness, which just means dizziness coming from the neck. And we have different assessment and treatment techniques for that too. So if someone comes in dizzy, the first step is always figuring out like where that's coming from.
Yeah. No, definitely figure out what the cause is and then treat the
Mhm.
cause. And yeah, it's definitely an interesting one. I've worked with a few cases of BPPV, so I treat in my scope. So if it truly is that condition and they're referred for that specific issue by somebody, then I can treat it. But if it's a different type, then it's a bit tough. I'll still assess somebody and then refer to a colleague. So in this case, it'd be Rob. Previously, there was a couple of people I knew. I never really met them, but I knew they did good work. So now I don't have to send them anywhere other than here. I could just say, hey, go next door to Rob. Go to the next bed to see Rob. Okay. So, then we're just going to send the link to this person. Good question. Could you send me a link to this session? Yes. Easy.
There we go.
No explanation needed. So I'll remind myself to do that. Yeah. So a couple more minutes. If there's any questions. I'll have my TMD day as well. So next week, I'm thinking of doing one of the days to do TMD or TMJ rehab. So going through quite a few things there, I guess. And then Brandon, this week we'll have his pain science day on Thursday. Okay, no more questions. All right, so I think we're good. We'll give it a minute.
I can't wait for TMD.
Oh yeah, same here.
I have questions.
Okay, good. I have answers. I have videos. I use like an old YouTube video. And I think it was one of my mentors that used it in the past, and it just does such a good job. So it's just the most basic video, but I like it because it makes sense, and it made sense to me when I initially watched it, because the anatomy and stuff can be pretty complex. So it's always tricky teaching it in a way that everyone can understand. So I use this video even with kids.
Nice.
And they get it. Those are really good questions.
TMJ, the mouth joint. As far
Sure.
as I understand.
I was reassessed by like, could you eat a burger? Did you eat a burger last night? Yes. Okay. Discharge. Yeah. So if that's it, thanks for tuning in, guys. Rob and Sunny checking out. We had a good time.
Thanks so much.
Thank you to Rob for that wonderful presentation. So, someone left before even. Oh, you missed everything.
Yeah.
So yeah, thanks to Rob. That was great to get a bit more details on vestibular rehab. So feel free to email us or him, info@pursuitofmotion.com or rob@pursuitofmotion.com if you have more questions. And the link will be saved, so just shoot us a direct message if you want access to the link and to this video. Have a good one, guys. Share it to the story. I wanted to do one thing, Mr. Rob.
Oh yeah.
Couple things, if you have some time.
Yep.
I want to do a Tidex Tuesday post, like we always do.
Yeah.
But I have the idea. So the theme is always rolling the weight, playing the song, rolling around 30.
Yeah, love it.
Right, really there. So today's, I'm thinking of having you here. I did it that one day with the dog by myself. It was a nightmare. Because the dog is like old and deaf. Oh no. It's still recording.
Oh.
Well then, don't listen to that guy.